Hello everyone, I am Baisali Bharadwaj Dash, a student of 2nd MSc Food Science and Nutrition of Avnashlingam Institute for Home Science and Higher Education for Women. In this video, I'll talk about the nutrition and lifestyle changes during pregnancy. In this video, we'll see about metabolic adaptations during pregnancy, the importance and deficiency diseases of macro and micronutrients, avoidance of certain foodborne illnesses, and obesity. From gestational diabetes mellitus will continue in the next video. So the metabolic adaptations of pregnancy. These involve changes of carbohydrate and lipid metabolism that preserve maternal homeostasis and allow timely transfer of nutrients to the fetus in order to optimally support growth and development. In the early pregnancy, insulin-secreting pancreatic beta cells become hyperplastic, resulting in increased insulin secretion. Insulin sensitivity is enhanced and the fasting plasma glucose level are slightly reduced with only small changes in the insulin levels during first trimester of pregnancy. This increases the risk of hypoglycemia in some pregnant women. During the first and second trimester, estrogen and progesterone are increased, insulin concentrations favor lipid metabolism and inhibit lipolysis, which results in an accumulation of maternal fat stores. This accumulation peaks between 10 and 13 weeks of gestation. The maternal energy requirements are thus mainly met by the increased efficiency of glucose metabolism, and being in an anabolic state, excess glucose as well as dietary triglycerides are stored as adipose tissue. In the later pregnancy, the changes during the second half of pregnancy happen in the maternal metabolic patterns. The maternal insulin resistance begins to develop in the second trimester and it peaks in the third trimester. It is generated by the release of placental dibetogenic hormones such as human placental lactogen, growth hormone, corticotropin releasing hormone, human chronic somatotropin, and progesterone. And these shifts in the anabolic to the catabolic state and promotes the use of lipids as the maternal source while preserving glucose and amino acid for the fetus. This shift allows pregnant women to minimize protein catabolism and preserve glucose as the main fuel for the fetus. Why is it essential to know about the carbohydrate and lipid metabolism? Because adapting to this carbohydrate and lipid metabolism at different stages of the pregnancy ensures that the increased energy and nutrient requirements of the mother all match while providing and required nutrients for the fetus to ensure optimal growth and development. The fat deposition in the mother usually happens around the breast and the buttock and are beneficial to support maternal homeostasis and fetal growth during the third trimester. And they also act as an energy source during lactation. However, excess deposition of fat may have adverse consequences. So that was about the metabolic adaptations in pregnancy. Now we will see about the importance on deficiency diseases associated with macronutrients. The first macronutrient is energy, and as we all know, there are increased energy requirements during pregnancy, and this is because of the growth and physical activity of the fetus, growth of the placenta and maternal tissue, normal increase in maternal body size, additional work involved in carrying the weight of the fetus and extra maternal tissues, and slow but steady rise in the basal metabolic rate. The basal metabolic rate increases by about 5% during the first and second trimester and by about 12% during the third trimester. The ICMR recommended energy requirement for pregnant women is as follows. These values are the energy requirement for a normal adult woman, and in pregnancy 350 calories is added. So in a sedentary working woman, it is 1660 plus 350, which is equal to 210 calories per day, kilocalories per day. In case of moderate working women, it is 2480 kilocalories per day, and in case of a heavy working woman, 3070 kilocalories per day. Impact of energy deficiency in case of mother, abortion, complications during delivery, ketosis, and she may not gain enough weight to have normal lactation. In case of infant, premature infant, low birth weight infant, and less brain cells. This is the image of a premature infant. The next macronutrient is protein. Protein is essential for rapid growth of the fetus, enlargement of the uterus, mammary glands, and placenta, increase in maternal circulating blood volume, and subsequent demand of the increased placenta protein, formation of amniotic fluid and storage reserves for labor, delivery, and lactation, the transfer of amino acids from mother to the fetus. ICMR recommended protein requirement for pregnant women is as follows. For an adult woman, it is 36.3 gram per day. In case of pregnancy, in the second trimester, plus 7.6 gram per day is required. In the third trimester, plus 17.6 gram per day is required. Impact of protein deficiency is quite similar to energy deficiency. In case of mother, abortion, complications during delivery, ketosis, may not gain enough weight to have normal lactation. In case of infant, premature infant, low birth weight infant, and less brain cells. Next, we will see about the importance and deficiency diseases of micronutrients. First micronutrient is folic acid. We have already seen about folic acid in the previous video, which is vitamin B9, and it helps in the production of red blood cells, the neural tube development into brain and spinal cord. It is a source of DNA creation. It helps prevent miscarriage and preterm births, and it helps prevent neural tube defects. ICMR recommended folate requirement for pregnant women is 480 micrograms per day. Impact of folic acid deficiency are, in case of mother, megaloblastic anemia, abruptia placentae, and PIH, which is pregnancy-induced hypertension. In case of infant, fetal malformations, neural tube defects, spina bifida, congenital abnormalities, and low birth weight. These images are some of the neural tube defects in children due to folic acid deficiency. Next micronutrient is vitamin B12. It helps in the absorption and digestion of food and proper metabolism, thereby preventing gastric troubles. It helps in the smooth functioning of the nervous system. It promotes healthy nerve, spine, and brain development, prevents the risk of anemia, boosts the immune system, help effectively combat the various pregnancy symptoms like fatigue, weakness, mood swings, and constipation, and it helps in the production of DNA. ICMR recommended vitamin B12 requirement for pregnant women is 2.2 micrograms per day. Impact of vitamin B12 deficiency in case of mother, pernicious anemia, in case of infant, premature baby. Next micronutrient is vitamin D. It is a highly essential nutrient as it enhances the maternal calcium absorption. Its active forms like calcidiol and calcitriol cross the placenta and play an important role in calcium metabolism of the fetus. ICMR recommended vitamin D requirement for pregnant women is 400 IU per day. Maternal deficiency of vitamin D results in neonatal hypocalcemia and hypoplasia. Excessive vitamin D can also result in complications such as atherosclerosis, hypercalcemia, calcium deposits in vital organs, and mental retardation in the infants. Next is calcium. In pregnant women, calcium fortifies the breast milk, produces fewer body fats, thereby lowering the risk of obesity, helps in proper functioning of nerves, maintains a normal heartbeat, and facilitates normal blood clotting. In the fetus, calcium is crucial for strong dental growth, aids in nervous system development, helps in the formation of muscles, and develops a strong heart. ICMR recommended calcium requirement for pregnant women is 800 milligrams per day. Impact of calcium deficiency in case of mother, muscular cramps, repeated pregnancy with poor diet can result in osteomalacia. During lactation, breast milk may be deficient in calcium. In case of infant, calcification of bones and teeth is decreased and underweight due to decreased fetal bone growth. Next micronutrient is iron. Iron is essential for avoiding anemia. It helps in growth of fetus and placenta, formation of red blood cells. It helps in the baby's brain development and is necessary for brain processes such as myelination, neurotransmitter production, and energy metabolism. ICMR recommended iron requirement for pregnant women is 32 milligrams per day. Impact of iron deficiency in case of mother, hypochromic macrocytic anemia and complications during pregnancy. In case of infant, born with less stores of iron and susceptible to anemia. Next micronutrient is iodine. Iodine is essential for brain and nervous system development, proper formation of thyroid gland in the fetus, regulation of metabolism, and it helps in the various functions of the cardiovascular system, reproductive system, and central nervous system. ICMR recommended iodine requirement in pregnant women is 180 micrograms per day. Impact of iodine deficiency in case of mother, goiter and increased risk of miscarriage and stillbirth. In case of infant, chances of getting goiter and criticism. So that was all about the importance on deficiency diseases associated with macro and micronutrients. Now we'll see about certain foodborne illnesses that should be avoided during pregnancy. First is listeriosis. Listeriosis is caused by the bacteria Listeria monocytogenes. This is the image of the bacteria. Listeria can contaminate a variety of raw foods such as uncooked vegetables and meats, unpasteurized milk and soft cheeses, and they tend to invade the placenta and the fetus and may cause severe fetal and neonatal infections. The consequences of these fetal infections are preterm birth, neonatal sepsis, meningitis, and death. Prevention. All pregnant women should be informed during their normal placental care about food preparations, food preparation practices, and avoid foods with high risk of contamination. The four cornerstones of safe food preparation should be followed, which include clean, separate, cook, and chill. High-risk food should be avoided, like raw and not fully cooked meat. Only meat that is thoroughly cooked is really safe. Soft cheeses, smoked fish, and pre-prepared and pre-packed salads should be avoided. Fresh fruits, vegetables, and salad must be thoroughly washed and freshly prepared and soon consumed. Next is Salmonella. Infections caused by Salmonella species are most common cause of foodborne diseases. There are specific complications that are associated with the infection during pregnancy. Septic infection of the mother can result in spontaneous abortion. If transmission to the fetus occurs, this can cause preterm births and neonatal infection of the brain and meningitis. This is the image of Salmonella. Prevention. Pregnant women should avoid raw or undercooked eggs, poultry, and meats. Many foods like hollandaise sauce, mayonnaise, Caesar and other salad dressings, tiramisu, homemade ice cream, cookie dough, and frostings contain raw eggs and should be strictly avoided by pregnant women to reduce the risk of salmonella infection. It is also important to adhere to proper hygiene precautions when handling raw meat or poultry, like washing hands, work surfaces, and utensils immediately after contact. Next is toxoplasmosis. Toxoplasmosis is the third major cause of foodborne disease deaths in the world, and it is caused by intercellular parasite Toxoplasma gondii. This is the image of Toxoplasma gondii. Toxoplasmosis vertical transmission increases from 10 to 15% in the first trimester to 44% in the second trimester and to more than 71% in the third trimester. Infection of the unborn child can have devastating neurological and ophthalmological consequences, and it can induce cardiac malformation. Prevention. The screening policy and information and prevention of Toxoplasma gondii should be provided to the pregnant women during preconception care. Prevention can be carried out with specific hygienic and dietary recommendations. Cats are identified as transmitters of Toxoplasma gondii, so care should be taken while handling cats. Meat should be frozen to at least minus 20 degrees Celsius or minus 4 degrees Fahrenheit, which can effectively kill Toxoplasma gondii. So next we'll see about obesity. An individual is termed as obese if the BMI value is 30 or higher. In case of pregnant women who are obese, they are faced with various health risks that extend to their unborn child. According to the World Health Organization, obesity during pregnancy has a prevalence of 1.8 to 25.3%. Pregnant women face health complications such as gestational diabetes and preeclampsia and a need for cesarean delivery, which could be associated with complications. Obese women are exposed to health risks such as gestational diabetes, which is a condition in which diabetes appears for the first time during pregnancy and subsides after delivery of the baby, but increases the future risk of suffering from diabetes. Blood clots. Obese pregnant women have higher chance of developing blood clots in blood vessels than non-obese women. Then is preeclampsia. It is a condition associated with high blood pressure and high protein levels in the urine, which can cause swelling in the ankles, feet, and hands, pain in the ribs, vision issues, and headache. Pregnant women who are obese have an elevated risk of vitamin D deficiency. There can be other complications during delivery, like chances of bleeding, cesarean sections, and higher risk of complications, including infection and complication due to anesthesia. These are the references that I've used to make the PPT and the video. Thank you for your patient listening. We'll continue from gestational diabetes in the next video. If you like the video, please do like, share, and subscribe to my channel. Thank you.